Hello, everyone. Today is lecture number 3 of our body fluid series, the osmosis. By the time you finish this session, you will never look at the bag of IV fluids the same way again. You will understand why a malnourished child has a swollen belly and why a diabetic runs to the bathroom every hour and why we use mannitol in the patient with the traumatic brain injury. Osmosis is not a passive concept. It is an active clinical tool. So let's begin. Our primary objective in this pretty session would be to describe the role of osmosis in edema. But we will go further. We will differentiate between hydrostatic and oncotic edema. We will calculate plasma osmolality at the bedside, and we will predict what happens to the RBCs when a nurse accidentally runs 0.45% saline instead of 0.9% or the normal saline. For your information, osmosis is live. Let me prove it. For this session, for this topic, I recommend strategy for the theoretical clarity and Mustaq for the exam-oriented MCQs, right? But my lecture notes, which you have, contain clinical things not found in any other textbook in a compiled way. So review them before the next internal assessment. So let's begin with the definition of osmosis. Osmosis is the movement of solvent or the water across a semi-permeable membrane from a low solute concentration to high solute concentration. Many students reverse this. Repeat after me. Water follows the salt, or more precisely, water moves towards where there are more particles. Why? Because the system wants to equalize concentration. This is passive, requires no ATP, and is driven by entropy. So, here is a clinical pearl for you. When you give IV mannitol, you are artificially increasing plasma solute concentration. Water then moves from the brain into the blood. This is how we reduce cerebral edema. Let's have a look on osmotic pressure thing, right? Osmotic pressure is the pressure required to stop osmosis. It is directly proportional to the number of particles, not their mass. This is key. 1 gram of NaCl has many more particles than 1 gram of albumin because NaCl is tiny and dissociates into its two ions, right? That means small molecules exert high osmotic pressure per gram. So if you give a patient 100 grams of glucose versus 100 grams of albumin, then glucose will pull far more water. That's why we use small molecules, mannitol, glucose, or saline, NaCl, for osmotic therapy, not the albumin thing, right? So let's talk about ionizable compounds and isoosmotic compounds, right? NaCl dissociates into sodium and chloride. So 1 molar NaCl is equal to 2 osmoles, right? Glucose does not dissociate, right? Glucose does not dissociate. So equals to 1 molecule of glucose. And that is equal to 1 osmole. Therefore, 1 mole NaCl exerts double the osmotic pressure of 1 mole of glucose. Solutions with the same osmotic pressure are isoosmotic, but beware, isoosmotic does not always mean isotonic. Why? Because the solute, like urea, can cross the cell membrane it will not maintain cell volume. True isotonicity requires a non-penetrating solute. So, for humans, 0.9% of the NaCl is both isoosmotic and isotonic. Urea, 2% is isoosmotic but hypotonic in action. It enters cell and water follows it. This is a classic experiment you will see in your either in biochemistry lab or the physiology lab, right? Or practicals. 0.9% NaCl, that is isotonic, RBC's volume unchanged, and the cell size remains intact. What about the case when given with the 1.5% of NaCl, that is hypertonic? Water leaves the RBCs, cell become shrunken, right? So that look like spiky balls, right? When you give 0.4% of NaCl, that is hypotonic in nature, water enters the RBCs, cell swell, and ultimately that causes the hemolysis or the rupture or releasing the hemoglobin. So, clinical correlation for your guidance, right? And hyponatremia, low plasma sodium. Plasma is hypertonic. Water enters brain cells, cerebral edema occurs, and that leads to the symptoms confusion, seizures, and coma. We correct this condition slowly to avoid osmotic demyelination. What about in case of hypernatremia or the high sodium concentration? Plasma is hypertonic. That case, the water leaves brain cells. Brain shrinkage is the outcome. So there's high likely chances in case of brain shrinkage, the rupture of veins, and that leads to intracranial hemorrhage or the brain hemorrhage. Now, let's talk about the RBC fragility test. RBC fragility test is used in hereditary spherocytosis, the increased fragility, and thalassemia, the decreased fragility. Now, let's talk about the type of solutions and let's have the details. So, let me make this clear, very crystal clear concept here. Isoosmotic means the same total osmotic pressure, means same milliosmol per liter as plasma. This is for the isoosmotic thing, right? And isotonic means same effective osmotic pressure for the each cell, right? So no net water movement across the cell membrane. For example, 5% of glucose is isoosmotic, but not isotonic in the body because glucose is rapidly taken up into the cells, leaving pure water behind. So 5% glucose becomes hypotonic in the bloodstream. That's why we don't use it for volume resuscitation in shock conditions. It can cause cerebral edema. So for resuscitation, we use 0.9% of the NaCl or balanced solution like Ringer's lactate. What is oncotic pressure? Oncotic pressure is the osmotic pressure due to the colloids, mainly the albumin, then the globulins. Total plasma oncotic pressure is 25 to 28 mmHg, which is small compared to the total plasma osmolality. But here's the secret. Oncotic pressure is the only force holding water inside the vascular space. And hydrostatic pressure pushes water out. Oncotic pressure pulls it back in. That is the concept behind the Starling forces, right? So, what about the clinical things for you right now? In case of low albumins, that occurs in case of cirrhosis, nephrotic syndrome, or the kwashiorkor, there will be a low oncotic pressure. Then water leaves the vessels, right? That leads to edema and ascites. What about the diuretics alone? Diuretics alone don't fix this. You need to raise oncotic pressure along with albumin infusion. So treat underlying cause or disease. What about high oncotic pressure in case of dehydration or multiple myeloma? Water pulled into the vessels and there will be a relative hypovolemia of the interstitium. Now let's have some basic definition of things, right? One osmol is equal to 1 mole of undissociated particles. For example, 180 gram of glucose is equal to 1 osmol, and 58.5 gram of NaCl is equal to 2 osmoles because it gives rise to sodium and chloride ions. So plasma osmolality is 280 to 300 milliosmol per liter, right? Now, let's have a look on the applications, right? The very first one is, transfusion solutions, right? The two most common IV fluids in the world are 0.9% NaCl, that is normal saline, that is isotonic in nature, stays in the extracellular fluid, good for resuscitation, dehydration, and burns. And the second one, that is 5% glucose, the D5W. Initially isotonic but becomes hypotonic after glucose metabolism, used for maintenance, not the shock condition. So never give pure water intravenously. That will ultimately or instantly lead to hemolysis. So in case of diabetic ketoacidosis, we start with the 0.9% of saline, then switches to 0.45% saline once glucose drops, right? The reason being because hypertonic saline can worsen cerebral edema and DKA or diabetic ketoacidosis. What about the purgatives, right? Or osmotic laxatives? Magnesium sulfate, that is Epsom salt, and sodium sulfate, that is Glauber salt, are non-absorbable or poorly absorbed. They remain in the interstitial lumen and creating a hypertonic environment. Water is drawn from the blood into the gut lumen, and softening the stool and stimulating the peristaltic movement, right? So clinically, we use purgative in case of constipation, bowel preparation before colonoscopy, and acute poisoning to make sure the flushing out the ingested toxins, right? What about the dangers linked with, giving purgatives? There are high likely chances to have dehydration, electrolyte imbalance, and they are not considered a good use for a prolonged use, right? What about the osmotic diuresis and how you define osmotic diuresis? This is a cornerstone of the clinical medicine and uncontrolled diabetes. Blood glucose exceeds the renal threshold, that is 180 milligram per deciliter. Glucose spills into the urine because glucose is an osmotically active particle. It pulls water with it. So resultant would be polyuria, large volume of dilute urine. The polydipsia, that is increased thirst, right? And the dehydration. Osmotic diuresis versus Water diuresis. Let's have a look on that, perspective. Water diuresis can or one can have, experience in case of diabetes insipidus, right? That leads to diluted urine and normal sodium condition. What about osmotic diuresis? One can see in diabetes mellitus or mannitol infusions, right? So urine with high solute load and sodium usually normal or high in this case. So therapeutic osmotic diuresis are the mannitol is given intravenously to reduce intracranial pressure or promote excretion of toxins. The lithium overdose. So mannitol is filtered but not reabsorbed, so waters follows, right? Edema due to hypoalbuminemia. This is one of the most clinically relevant slide, right? Causes of hypoalbuminemia include kwashiorkor, that is protein malnutrition, low dietary protein intake, that ultimately leads to low albumin levels, or that leads to generalized edema, fatty liver, skin lesions, right? The other condition that causes hypoalbuminemia are nephrotic syndrome, cirrhosis, glomerulonephritis. And what about the mechanism behind it? Low plasma oncotic pressure. There will be net filtration exceeds reabsorption at the capillary level. So fluid accumulates in the interstitium. So how you treat that condition? Ultimately, you will correct that underlying disease. May you need to settle the dietary requirement, right? Sometimes you need albumin infusion, right? Sometimes. And diuretics alone are ineffective without correcting oncotic pressure, right? So differentiation from cardiac edema. Let's have a look on this perspective as well. Cardiac edema that one can experience with the high hydrostatic pressure, and that leads to, one usually starts in dependent areas. The ankles worsen with the standing, and hypoalbuminic edema can be generalized, often with ascites, but no jugular venous distension can be seen in hypoalbuminic edema. So let's talk about cerebral edema and wound irrigation. Hypotonic line, the 3% or the 5% mannitol. And mannitol are mainstay for the therapy, right? They increase plasma osmolality, drawing water out of the brain tissues across the intact blood-brain barrier, right? So there's a question for you, right? Traumatic brain injury with impending herniation, we push mannitol zero point 0.5 to 1 gram per kg IV bolus. So that causes the effect in 15 to 30 minutes, right? Next is the wound irrigation. Why does salt on a wound hurt? Because salt creates a hypertonic environment, drawing water out of the exposed nerve endings that ultimately mechanically stimulating brain receptors, right? So that's why we use isotonic saline to wash wounds. No osmotic pain, no cell damage. So next is the dialysis. We'll discuss in the next session in very detail about the dialysis. And this is one of the clinical implication or the application of the this pretty physicochemical property of body fluids. That is that we discuss in very detail, as this is very important topic that being taught in theory classes or the lecture sessions, and along with the skill lab or practical classes, right, as well. So stay tuned for the next session on the dialysis. Thank you very much.